Good morning. Well, I'm very, very pleased to be able to provide a little bit of insight onto quite a diverse array of spotlight posters this morning. As George was saying earlier for this session also, these were really quite excellent posters that really provide, I think, again, quite a diverse insight into some of the management. And now as George really laid it out, is he says, well, now what are some of the additional things that we can do to monitor patients? So we're going to talk about some of these biomarkers. Let's go on to the next slide. So the abstracts that we're presenting today, Dr. Schneider is abstract or PD 910, Dr. Lintz, Dr. Godarzi, Dr. Pinole, Dr. Leubel, and Dr. Stover, and we'll spend a little bit of time on each of these this morning. So I've kind of created an outline to put this together. I found, by the way, that because this was so diverse, it was kind of hard to make an outline, but here's my attempt at it. I think we're going to start out with the whole idea of residual triple-negative breast cancer after neoadjuvant chemotherapy. And we certainly know that for this group of patients that there's a very high risk of recurrence. And so Dr. Schneider and colleagues are really trying to tackle this important question by utilizing a precision-based approach to target these high-risk patients. And we're going to talk a little bit about their study. That really leads us on to the idea of these blood-based biomarkers that really can identify minimal residual disease. We have a lot of data now with regard to these, and the question is, do they have clinical utility? And also, are there some additional novel biomarkers? Then we kind of move over to ER-positive, HER2-negative breast cancer. And first of all, a poster that really extends on the prior session, which is a multi-gene marker, EndoPredict, and certainly just further nice validation for this. And then a novel approach to target potential drivers of endocrine resistance, and we're going to talk about the MDM2 amplification. And then finally, by Dr. Stover, modifiable host factors. And question that comes up is, do changes in some of these host factors, we talked about them, can they potentially alter breast cancer phenotypes? So this is a paper that Dr. Fraser Simmons presented 2 years ago, and it says Lancet Oncology 2021. It should be saying in press, I believe. Is that right? I think it's a couple more days or tomorrow. But this really just shows you very nicely, again, the importance of residual and measuring residual disease after neoadjuvant chemotherapy. And for these patients here with triple-negative breast cancer who have residual disease, you can see that they have a very high risk of recurrence. And this is really the focus of a number of emerging approaches. Of course, we have the CREATE-X study, which for the first time demonstrated benefit of capecitabine. And then Ingrid Meyer recently presented and published, the EA1131, which was looking at the question of platinum. And of course, unfortunately, in that particular study, there was not an improvement in outcomes with the use of platinum-based agents versus capecitabine. But again, we certainly got insight into the fact that this is a very high-risk group of patients. So in that context, Dr. Schneider and colleagues designed a trial where patients who had prior neoadjuvant chemotherapy and who had significant residual disease at the time of surgery, they underwent a sequencing approach, and using that sequencing information, they used a prioritization scheme to identify drug targets. They used a tumor board, and they randomized patients to either a molecularly directed agent or to a standard therapy. And as you can see, which is right at the bottom, that there was no improvement, that is, with regard to the use of a molecularly directed agent versus standard therapy. So I think the question is, this is what I would call a shot across the bow for approaching patients with this high-risk disease and trying to improve the outcome. And a question comes up is, why did this study not reach its endpoint? And I think probably the first is, we need to use drug targets and drug pairs that really have adequate preclinical and clinical anti-tumor activity. And as you can see here, these are the ones that were used by the authors: pembrolizumab, olaparib, gemcitabine, crizotinib, They used a number of different agents associated with some genomic findings. And as I said, this was really a first approach to really utilize a personalized approach to improving outcomes. But I think we can also take and learn from the recent Sapphire study. It was just presented by Fabrice Andre just a couple days ago. It was presented here. And in that particular study, as you know, one of the things that they did was to ask the question of whether a precision medicine approach could improve outcomes in using genomic alterations. And what they did in the study, though, was very important, is they restricted their drug-gene pairs to those that where they really had a hierarchical way to prioritize. So they used Tier 1 alteration drug match associated with improved outcomes in clinical trials, or Tier 2 alteration drug match is associated with anti-tumor activity, but the magnitude of benefit is unknown. So as you know, this particular study showed that there was an improvement in median PFS. But I think one of the things that's very important to point out is that as you look at this approach where you lump all these drugs together, it's very possible that you could have one drug that is driving the entire benefit. You can see here olaparib. And you have a smattering of other drugs targeting different alterations, for example, alpelisib and a couple of other drugs here. You can see where potentially we don't really know whether these drugs really do improve the outcome. And so I think one of the things I would say here is that studying drug-gene pairs of preclinical and early clinical validation is really a key to moving to the clinic. And I think also when we're studying this, we really should be prioritizing drug and drug-gene pairs where we actually have clear evidence of anti-tumor activity in chemotherapy-resistant triple-negative breast cancer. And these models are out there, they're available. You can use PDXs, you can use organoids, of course, genetically engineered models, but these are the clear ways that we need to move forward, and we need to be studying the biology of chemotherapy-resistant breast cancer and then moving them into the space. So Dr. Schneider and colleagues I noted that are taking forward a study that, and I congratulate them, that's just recently activated called the Persevere study. And this time they're focusing on this even higher risk group of patients that are ctDNA positive, and we'll talk a little bit about that. And in that particular study, they're combining, they're using capecitabine, a standard of care in this situation, and adding additional drug based on a number of different biomarkers. And I'm not sure, I didn't welcome to my email, so I'm not sure how to get rid of that, but I'm going to click that. All right. Okay, so let's talk a little bit about additional biomarkers to assess prognosis. We all know about the emerging data of minimal residual disease in this space. The Indiana University, Dr. Radovich and Dr. Schneider published these data in JAMA Oncology. Others have published in this area. This is just an update of their original data that was published in 2020. And again, you can see ctDNA positive patients clearly have a higher risk of disease in this situation. So with that, we move on to the next abstract. This was presented by Dr. Lintz et al. This is a very interesting study looking at peripheral immune subsets in circulating tumor DNA. And this is an ongoing study. It actually hasn't read out. It's a small study, certainly hypothesis generating, residual triple-negative breast cancer, randomizing to one of 3 arms, nivolumab, capecitabine, or a combination of nivolumab and capecitabine. And the authors did note that they did see some changes in circulating immune biomarkers, and that differed by treatment arm. We don't have the primary outcome from this trial as of yet. But again, I just want to point out, and they certainly show it here, is that these patients that have positive ctDNA assays clearly have a very, very high risk of distant disease-free survival. But what you want to point out here is really important. You're going to run a trial like this, you better make sure that you actually have equal numbers of ctDNA positive patients in each arm. Because take a look at that in these 3 arms, you have obviously a substantial increase in one arm, and so you may be making wrong conclusions about the activity or lack of activity with your drug if you don't stratify. And so I think one of the things that we can learn from this is that clearly these ctDNA positive patients have a higher risk of disease progression. And I think we still have this question of clinical utility. So if we identify a ctDNA positive blood test, will it result in an actionable intervention that will improve the outcomes of our patients? That's true clinical utility, and I think we're still working on that. Is it important for trial design? I think the answer is yes. So I think, the question is, as we're running these trials, we're going to need to use ctDNA potentially as a stratification factor, because if we don't, we're obviously could potentially have imbalances, and especially with smaller studies. So I also think that, this has implications for trial design, which drug genes combination, which biomarkers, and I think the point I'll make here is that this is a rapidly moving area. So even now, if you were to design a trial in this space based on a drug that you think is active 6 months ago, things could actually move, and it's the reality of our field. But I think this is a very important place to study, and I think I'm very encouraged to see prospective studies in this space. So this next particular study, and it looks like for some reason one of the slides did not come through, but this is a slide by Dr. Goodarzi looking at a novel-based blood-based biomarker called circulating orphan non-coding RNAs. And I would refer you to the poster for the image that, for whatever reason, didn't come up there. But at the bottom line is these orphan non-coding RNAs are quite interesting. They appear to be cancer-specific small RNAs that emerge from cancer cells. The authors and others have developed this a oncRNA fingerprinting test. It's an ability to extract total cell RNA and identify these circulating orphan non-coding RNAs. And I think what you can see is when they looked at these, they analyzed some blood from patients that were enrolled in the I-SPY trial. One of the things that you could see, of course, was that this certainly seemed to be associated with disease burden. So in patients that had higher residual disease, there was higher amount of these circulating orphan non-coding RNAs. But interestingly, it appeared that this particular biomarker provided independent prognostic information. And so I think as we think about this, the questions that come up for me is this a more sensitive biomarker than ctDNA? And I think further, for ctDNA positive or negative patients, could this particular biomarker identify additional subgroups of patients, either at an increased or decreased risk for recurrence? I think the other question is, are there differences in the performance of these by breast cancer subtype? I would like to see, as you go across the different breast cancer subtypes, do we see specific of these orphan non-coding RNAs emerge? And then, of course, finally, is there a path forward for clinical utility? And I think the more we study, then the more we're going to get insight into whether that indeed is the case. We're actually going to, in the last few minutes, spend just a little bit of time on ER-positive, HER2-negative breast cancer. I'm going to just spend briefly very few slides on EndoPredict because this was touched upon in the prior session. And then a novel approach to target a potential driver of endocrine resistance in ER-positive, HER2-negative breast cancer. So this is a presentation by the UCBG group where they looked at the prognostic value of EndoPredict in the UNIRAD study. As you recall, this study was a phase 3 international trial that evaluated the addition of everolimus to adjuvant hormonal therapy. So unfortunately, this overall trial was negative, but this trial provides the authors and all of us to see additional information about the prognostic effects of the EndoPredict test. So what is the EndoPredict test? Again, just as a recollection, it's a multi-gene test that comprises 12 genes. There's 8 genes that are linked to proliferation pathways, apoptosis pathways, and hormone receptor pathways. There's 4 control genes as well. And they combine this with 2 clinical risk factors, tumor size and lymph node status, and that comes with the so-called EndoPredict or clinical EP. So in this particular study, what they did was they had a group of patients that were very high risk that were enrolled in the trial. These were patients that had greater than 4 positive lymph nodes. But they had this subgroup of patients that had 1 to 3 positive lymph nodes, and they had EndoPredict testing. Those that were high risk were randomized. And I think what you can see from this study is, I think overall, this is just, by the way, a brief about the fact that there was no value of everolimus overall in the study and no predictive value of EP-Clin. But again, what you can see is that EP-Clin clearly provides prognostic information. And I think what's quite remarkable is the fact that in the very low-risk group, there was actually no events. So this, in this prospective, what I would call, clear validation, really tells us that EP-Clin can identify a very low-risk group of patients that clearly do not need any additional therapy other than hormonal therapy. So again, this score was validated and node positive. It's been validated in a number of different settings. This is just another setting. I think it's a remarkable lack of events in this low-risk group of patients. Of course, we have level 1 data from my standpoint that this test is prognostic. I think these high-risk patients, what are we going to do with these higher-risk patients? Well, I think what we're seeing at these high-risk patients that chemotherapy is not the be-all, end-all. These patients are still recurring, and so we're going to need to identify additional treatments to target these higher-risk patients above and beyond chemotherapy. I think it's going to be a little more complex because this is a heterogeneous group of patients. There are a number of biological factors that are driving recurrence in this group of patients. The next poster here is focusing on specifically one gene. It's MDM2. MDM2 gene amplification. We've seen a lot of information on MDM2 in a number of different tumors over many years. It is a gene that is responsible for regulation of P53. We know from other studies that MDM2 gene amplification tends to be a poor risk factor that is associated with resistance to a number of therapies. So Dr. Loibel and colleagues presented this study that demonstrated, and I'm going to summarize it here for the sake of time, that MDM2 gene amplification facilitates growth and progression in an estrogen receptor positive preclinical xenograft humanized NSG model. If you treated cells with MDM2 either knockdown or targeting, that you can inhibit proliferation, migration, and that with MDM2 gene dose is strongly associated with the unfavorable outcomes of luminal A breast cancer, and that the prospective studies are further required. So I would just make a couple of comments. So this was derived from the Gebkar trio cohort of patients, and they used a clinical assessment of biological factors to assign luminal status. So luminal A was identified as patients that had a Ki-67 of less than 20%. Luminal B is those that have greater than 20%. And they used a dual-color fish to monitor MDM2 and assess for MDM2 amplification. So a couple things you can see in terms of luminal A. You can see that MDM2 appeared to be a driver here associated with higher recurrence in this luminal A group. Whereas in luminal B, I think you can see that it didn't obviously appear to be associated with outcome. I think you can also see from this is that the luminal B group clearly appears to be doing a bit worse. So I think a question that I had for the authors, is this really luminal A versus luminal B? When we use Ki-67 to classify luminal status, obviously what we know is that it's incomplete or it doesn't give us the full assessment truly of the biological, if you will, the so-called PAM50. And again, I apologize because my graph is not showing up, but what I did last night was just looked at quickly MDM2 copy number in PAM50 in a cohort of 140 male breast cancer patients treated with neoadjuvant chemotherapy where we derived PAM50. And the bottom line is that it looks like luminal A, I didn't see, at least by PAM50, any MDM2 amplification, but clearly I did see evidence for it in the PAM50 luminal B. So I think the point is, if you look across at these biological markers, these multi-gene markers, such as EndoPredict, such as the Oncotype DX, these low-risk patients, you're probably not going to find MDM2 amplification in that, but it may be more likely in this higher-risk group of patients. I think, nevertheless, this is really an interesting article, and I think the question is, in the metastatic setting, because that's always, of course, where we would think about applying this first, is this still a prognostic factor? Could we co-target MDM2, either following CDK4/6 inhibitors or in conjunction? And I think in the adjuvant setting, in this higher risk group of patients, What we're going to start doing, of course, is treating with abemaciclib. This is already happening based on the recent FDA approval. And I think question there is this still prognostic in this situation? And if so, would there be a benefit for targeting MDM2 along with a drug like abemaciclib? And then just the last few minutes, I'm going to focus on a question with where it relates to modifiable host factors, BMI and diet. So I think a question here that the authors are trying to raise, Dr. Dan Stover and colleagues, is do changes in host factors over time alter breast cancer phenotypes? And one of the things that we know, of course, is that something like body mass index is correlated with systemic inflammation. This may influence inflammation with within the breast microenvironment. We also know that there are additional factors. Physical activity, of course, is being extensively studied prospectively in a number of studies, such as the Be Well study. We know about dietary inflammatory potential score. These have all been implicated potentially not only in the risk of developing cancer, but also potentially in the tumor immune microenvironment. So I think the authors here are taking advantage of a number of very nice resources. This is within the Nurses Health Study cohort, where there's extensive data that's been generated over a long period of time, where they have information about not only body mass index, but since the age of 18, has there been a change in that over time, and other dietary factors. And these are really carefully followed patients where they can assess this over time. And I think the bottom line is that the authors are really try to identify and utilize the breast cancers that arose in these patients, identify a number of multi-gene tumor immune scores, as well as by looking at some biomarkers, including individual IHC markers, for example, for CD4 and CD8. And the bottom line is that what they did see is that a CD8 T-cell related gene expression signature, the so-called Gebtar-Sixto immune activation signature, was correlated with the CD8 IHC. I think we would have expected that. They didn't see any correlation between physical activity and immune cell specific expression scores. And neither did they see either the EDIP score associated with a number of immune scores as well. They did see some association between CD4 and CD163 with changes in BMI since the age of 18. So I think my questions for these particular authors are going to be, what would be a more optimal platform to identify and quantify novel immune-based biomarkers? And I know that Dr. Stover and others are working on in this area in developing new markers. And I think the second question is, what is the best approach to further validate whether lifestyle factors modify the phenotype of cancers that arise in this setting? I think we have a wonderful study that has recently, I'm not sure if it's completely closed yet. It may be, and that's the Be Well study that's being done within the Alliance. And certainly, I would hope that some of these factors could be looked at very carefully there. So I will stop there. Thank you.
Matt, thank you very much, Matt, for an excellent discussion of a diverse set of posters, excellent posters, and yet a diverse set. So if anyone has any questions here in the audience, please come up to the microphone and direct your question to the specific author. If not, those who are virtual, please submit your questions to Slido. Currently, we don't have any questions. However, there is just one comment, and then Fraser, I'll let you chip in. It says, I do agree with your amplifications in genes are a hallmark of luminal B tumors rather than luminal A. So, Fraser?
Thanks. I have a question for Dr. Pinanyoka. Freddie, we've seen in recent trials with CDK4/6 inhibitors, for example, that high-risk populations actually have a fairly low event rate in the first few years. And even in those studies, we're seeing curves that separate after a couple of years, and then that's when you start to see the effect. And I wondered whether the UniRAD study will be continuing to get longer-term follow-up and whether any of the predictive hypotheses are going to be reanalyzed. Oh, you're on mute, I think, Freddie.
Yes. Sorry. Yes, thank you for your question, Fraser. We plan to continue the follow-up for those patients to monitor also for the late recurrence. So I hope that we will have those data. And we also have Ki67 data. I didn't present them there, but it would be also interesting to look at that.
Thank you.
So I have a question for Dr. Stover. Do you know if there's any correlation with these immune subset patterns with cytokine levels in the blood of patients?
That's a great question. Thanks so much. Thanks for the opportunity to present our work, and especially on behalf of Sarah Assad, who can't be here. But it's a great question. I think, we're really interested whether host factors and systemic inflammation does have an influence. We're really heavily focused on tumor intrinsic factors, biomarkers, and then the immune cells that are already present. But what else is going on within the patient? And I think your point is well taken, that not only these potential exposures, but really the downstream effect of those, so like circulating cytokines, I think are a great follow-up. Nurses Health Study and some of these other large prospective studies do have some of those data, and that's something that we're definitely interested in looking at. And then in small prospective studies to sort of take a deep dive. I also appreciate Dr. Goetz's comment. I think Be Well will be very interesting. I think that sounds like there's deep correlative analyses, and we're certainly interested to hear more about the inflammation aspect.
A question, thank you very much. We now have a question from the audience. Dr. Loeb, could MDM2 be related to PR expression? Did you consider PR isoform differences in luminal A versus luminal B tumors?
This is a very good question, thank you. We did not look at the PR level in the study, but certainly have the data, and everything, ER, PR, Ki67 was measured centrally. So we have the data and could have a look at the data, because we know that PR level, low PR level, have also bad prognosis, and there could well be a correlation with that.
Great. Another question came up for Dr. Stover. Since BMI is related to diabetes, should we consider metformin in this analysis?
Well, I think with the data that was earlier presented, in a large prospective randomized study, the effects broadly in terms of prevention, I think that question has been answered by others. But, I think that we're just touching on, subtle aspects of what is a very complex pathway of diet, of adiposity, and of inflammation, and many interrelated factors there. So I think, what the interventions are, I think, first we have to understand how this may influence the tumor immune microenvironment, but then how to affect similar change, I think, therapeutically is a great question.
Thanks. I have a quick question for Dr. Philippa Lintz. Regarding the flow cytometry of the peripheral blood cellular components in response to treatment in your 3-arm study, obviously it's small, but it was a very innovative data set, and it looked like things like natural killer cells were low with the Nevo, but when you combine Nevo with capecitabine, they went significantly up along with dendritic cells. Any comments about the future application of flow cytometry, cell sorting in these immuno-oncology trials?
Thank you for your question, and I wanted to thank Dr. Goetz as well for a wonderful discussion, and all my co-authors, without who this would not be possible. In terms of your question, so this was a collaboration with Dr. Jeff Schlom from NIH, and this was based on prior work that they have done looking at 30 markers by flow cytometry to identify different immune subsets. So I would say that our work just started. All that I presented here was the different subsets in each of the treatment arms, but now what we are trying to do as well is what were the changes that we saw associated with recurrences. And for example, not only by treatment arm that will be limited by what Dr. Goetz mentioned, that was the fact that circulating tumor DNA was not used as a stratification factor, but can the changes in the peripheral immunoscore explain, for example, those that did not clear the circulating tumor DNA, but have not recurred yet, or vice versa? So very interesting and more to come.
Great. Well, I think we're getting late in the hour. Thank you very much, everyone. I'd like to thank all of our participants for their excellent posters. I'd like to thank Dr. Goetz and Dr. Rees-Philo for outstanding discussions, and I wish everyone well. Be safe traveling home.